Well, good afternoon from Penn State Health. This is Ask Us Anything About Face Pain. I'm Scott Gilbert. Most of the time when we experience some sort of face pain, we associate it with a headache or a dental issue. In some cases, such pain that becomes more frequent or severe over time could signal something more serious, such as the condition trigeminal neuralgia. We're going to learn more about that today from Dr. Jim Mcinerney. He's a neurosurgeon here at Penn State Health, Milton, Hershey Medical Center. Dr. Mcinerney, thanks for your time, and welcome back to Ask Us Anything About It. We had you on before talking about Gamma Knife, and we'll be talking a little bit about that on this program as well. Let's start by talking about that ache in the face. You know, the toothaches and headaches are very common. What are the signs to you as a physician that someone might be dealing with something a little more than that?
Sure. Well, I mean, one of the things that I always say is I don't worry so much about things that come and go. I worry about things that come and stay. And that's certainly one of the things that's pretty common with trigeminal neuralgia. It's a very severe pain, so that's one of the differences. People will rate this as the worst pain that they've ever had. People who have had other severe pains like childbirth, heart attacks, kidney stones, those can all be really severe pains, and yet they'll often say this was worse than that.
Do they start like that, or can they start as a minor pain and get worse over
time? A lot of times they do start smaller, but one of the hallmarks of trigeminal neuralgia is that it comes and goes. And it tends to sort of, crescendo over time, and so it gets more and more severe, and the attacks become more and more frequent. And people will usually describe it as a like electric shock type pain or a stabbing pain, and really, really severe.
So what role do those things that the patient describes the pain, how they describe their pain, how does that factor into the diagnosis? How do you kind of break this down?
Sure. Well, one of the tough things about all pain syndromes is that they usually are what we call a clinical diagnosis, meaning there's no real gold standard test that says, this is the problem that you have. And so when we talk about a clinical diagnosis, what we have to go on is history, what a patient tells us about their pain, a physical exam, which unfortunately for trigeminal neuralgia is usually pretty normal, and then their response to treatment. Did they respond to the kind of treatments that trigeminal neuralgia usually responds to? And that's pretty much it. And so it's to a certain extent a trial and error type of process that allows us to focus in on what really seems to be the major problem.
You're watching Ask Us Anything About Face Pain from Penn State Health. I'm Scott Gilbert alongside Dr. Jim Mcinerney. He's a neurosurgeon here at the Milton Hershey Medical Center, and Dr. Mcinerney welcomes your questions and your comments. If you're having face pain, perhaps you know somebody who is, and you have some questions as to whether it may show signs of trigeminal neuralgia, feel free to add your questions in the comment field below this Facebook post. So we're talking a bit about diagnosis here, and it seems like so much of ruling in trigeminal neuralgia would amount to ruling out other things, right?
Correct. And we do sometimes get imaging studies. I mean, occasionally somebody could have a tumor or something else going on that we might see on an MRI. We will sometimes, welcome the opinions of other physicians, and even dentists. I mean, some dental things could look like trigeminal neuralgia, but very typically when somebody does have trigeminal neuralgia, the dental procedures aren't going to fix the problem. And that's one of the giveaways sometimes for us, is that somebody will come in having been to dentists and had teeth pulled and things like that, but their pain is still persisting.
So what's going on inside the body? What is it about the trigeminal nerve that's happening with it that's causing this intense pain?
Right. That's a really great question. And, we don't know this 100% because, pain's not an easy thing to experiment on. We don't experiment on humans, and animals often can't tell us when they have pain. And so we're limited in what we can actually see. But we believe that this is usually caused by a blood vessel on the inside of the head actually pushing against the nerve, and that pulsation every time, it's usually an artery, every time the heart beats, the artery pulses, and it's right up against the nerve, and it keeps on hitting it over and over and over again. And what we think happens over time is that causes the insulating fibers between the actual signaling fibers in the nerve to break down, and now all these fibers start to set each other off, which is why people, we think, have triggers, right? So it's a common thing with trigeminal neuralgia is people can't eat or brush their teeth or wash their face because they'll do something innocuous, and all of a sudden it'll set off this attack of pain. And that's why we think that happens, because now a normal sensation is now setting off a pain fiber that it shouldn't be setting off, and these abnormal signals are now coming back to the brain as pain. And that's what we believe is happening. So even though the pain is experienced out here in the face, the problem is actually back inside the head where the nerve goes into the brain.
So obviously some life-limiting traits here in this pain. What about life-threatening?
Well, pain is not life-threatening. It can be very, very severe. And, so sometimes when you say, well, it's not life-threatening, it sounds like it's not serious. This is serious because it is. I mean, it can make people not eat. It can make people not go outside. It can make people do things that, really limits their lives. And sometimes those secondary things like not eating could become, theoretically life-threatening. But pain in and of itself is not life-threatening. So that's the good news, but it still demands treatment most of the time.
You're watching Ask Us Anything About Face Pain from Penn State Health. We welcome your questions for Dr. Jim Mcinerney, a neurosurgeon here at Hershey Medical Center. Feel free to add them to the comment field below this Facebook post. If you know somebody who may benefit from this information, feel free to tag them in the comment field or share this post as well on your Facebook page and help to get the word out about this information. The culprit is the irritation of that trigeminal nerve. We were talking about that before. And I heard that it also can be caused by other conditions. For example, multiple sclerosis can lead to this. So there are, I guess, a few possible factors that can weigh in here.
Sure. And so one of the things that we try and do when somebody comes in with face pain is first and foremost to determine if it is what we call typical trigeminal neuralgia. That's really what's going on. Because the things that we do work best when it's trigeminal neuralgia. But there are other things that can give you similar symptoms. And probably the most dramatic of those is multiple sclerosis, where you can have a very similar phenomenon, but for an entirely different reason and giving you very similar symptoms. We do a procedure called a microvascular decompression where we actually do an operation looking for that blood vessel that we think is impinging on the nerve. But if you have multiple sclerosis, there's not going to be a blood vessel. So it doesn't make any sense to do an operation. And so we do have treatments. Radiosurgery, for example, is a really good treatment for that.
We call it gamma knife.
Yes, gamma knife radiosurgery. But we wouldn't do an operation. So that's why we have to make that distinction between, we would call face pain as a result of multiple sclerosis atypical face pain, even though it looks and sounds very much the same, but the treatment that it demands is slightly different.
So tell me about that treatment with gamma knife. It focuses many beams of radiation in one spot. What does that do to alleviate the situation?
Sure. So basically all of the treatments that we have, fundamentally what they do is they injure the nerve. And so with radiosurgery and the gamma knife, what we're doing is we're taking radiation and we're using that to injure the nerve. But the trick with radiation is not how can you hurt something, it's how can you not hurt everything else around it, because obviously there are important things around that nerve that we don't want to hurt, brainstem and other parts of the brain, for example. So the trick with the gamma knife is we actually take 192 low-dose sources, beams of radiation, and point them all at the same spot. And so very accurately, all those beams come together in one spot and are targeting an area that's just about 4 millimeters in size. And as you move away from that central spot, that dose of radiation goes down exponentially. So basically, the only thing that sees enough radiation to be damaged is what we target, which in this case is the nerve, and everything else around it is totally safe. And it sees radiation, but not enough to be damaged by it.
So you basically obliterate the nerve in that particular spot. Whereas in the other type of procedure you mentioned, it involves targeting the blood vessel. You're not obliterating the blood vessel. You're just kind of, you're trying to move it away from the nerve.
Correct. Exactly. So, and we take advantage of the fact that this is not usually a complete injury of the nerve. Just the way the nerve has evolved over time, the pain-carrying fibers tend to be much more sensitive and more likely to be injured by anything we do. And as a result, very conveniently, as we go to injure the nerve, they get injured first, and the normal sensory fibers don't get injured. And so usually people don't have any numbness or anything, any secondary effects as a result of this. They just get improvement in their pain, which is nice. When we move the blood vessel away, there's probably a little bit of injury to the nerve that goes on there too. But the main thing is that we stop that ongoing process of the blood vessel, hitting the nerve constantly over and over and over again. And so when we do that, that actually usually lasts a lot longer. That usually will last 10, 20 years or even a lifetime. But it comes at the price of a much bigger operation, more risk, more recovery, that kind of thing.
In some cases, are you able to handle this medically, or is that rare?
Sure. Well, you're asking me, and I'm a surgeon, and that's how we take care of it.
You're biased, right?
But no, in truth, most people, as I said, one of the things we're looking for is response to treatment. And so most people who come to us, if they haven't already had some medical therapy, we would put them on medical therapy, because if medicine takes care of this problem, well, that's a good thing. Because one of the things I tell patients with trigeminal neuralgia is you kind of have to think of this as a lifelong problem. It is very highly likely that it's going to come back again at some point. And really our first defense against that are the medications that we use. And if those medications work, then that's usually the best thing to do. And when we get involved is usually when it has responded to those medications, but it's gotten worse and the symptoms are getting more common, more frequent, worse, and that's when we think about intervening with something, because any procedure carries some risk and some recovery with it.
And to go back to the beginning of our conversation, toothaches and headaches often do respond to over-the-counter pain medications. The pain caused by this condition does not.
That's correct. So yeah, things like Tylenol or non-steroidal anti-inflammatories like ibuprofen or naproxen, even opioid medications usually don't help the pain of trigeminal neuralgia. The medications that usually work are actually things that are designed for seizures, things like Tegretol and Neurontin, gabapentin. And so it's very different types of drugs, but for whatever reason they work. We don't completely understand that, but we know that they do, and when they do, that's one of the things that we look to say, yeah, this is probably trigeminal neuralgia.
We welcome your questions here on Ask Us Anything About Face Pain as we get some great information here from Dr. Jim Mcinerney. He's a neurosurgeon here at Hershey Medical Center. Mary has a question. She says, I've dealt with having a headache in my temple areas and my nose literally hurts inside. She says this has been going on for about a year. I have a deviated septum, but it's not that. No congestion. Allergies are ruled out. She just has tests. Any ideas before I go back to the ENT? I know you can't diagnose her over the internet here, but any guidance from Mary as to how she might proceed?
Well, and this is the kind of story we sometimes hear. And usually the next step in that kind of a situation is to see a neurologist who will be the person who usually first treats somebody with those medications. And that's really the great way of trying to, that's the thing we can use as a tool to kind of clinch that diagnosis. If it responds to those medications, then it could be trigeminal neuralgia. And one of the things that we didn't say about trigeminal neuralgia before, but it always respects the face. It doesn't go into the neck or the back of the head or even the ear usually. So, when you have pain that is completely, staying somewhere within the realm of the face, and usually just one side, and that sounds very much like what was Mary was describing, then I think it would be a reasonable thing to try some carbamazepine, Tegretol, or gabapentin, Neurontin for a little while and see whether or not that made a difference. And that's how we would typically try and make that diagnosis or rule out that as a possibility.
Sure, we can check with the neurologist for those next steps. Good stuff. Another question here from Terry. She's asking if migraines could be a symptom of trigeminal neuralgia.
I wouldn't say that they're a symptom. I mean, migraines are their own thing and they're different. But sometimes people get diagnosed with migraines when they actually have trigeminal neuralgia. So sometimes that misdiagnosis can happen. I think most of the time migraines are usually, they involve the whole head. They're often accompanied with nausea and vomiting. Those are things that you don't usually see with trigeminal.
And also the worst pain of their life, which is similar to what you were talking about before.
Right, exactly. So that's why, and the people who usually tease out these details are neurology colleagues. And again, often by a little bit of trial and error in terms of trying different medications and seeing what people respond to, so that we can kind of get at, okay, is this more down this path or is it more down another path?
Trigeminal neuralgia is more common in women than in men, and more so in people over age 50. Do we know anything why that is the case?
We don't completely. As I said before, it's not an easy condition to study. But I do believe, it's definitely more common in older people than in younger people. It certainly happens in younger people, but the majority of patients that we see are in their 60s, 70s, and 80s. And you've got to think that in part is because that blood vessel that causes trouble is more likely to, has spent more time against the nerve, has been more likely to get there over time, over the years of somebody's life. We're not generally born that way, so it takes some time to get there, and I think that's probably why we tend to see it more in older people.
To back out a little bit, I think with any type of pain for which people are told there is no cure, because this is not Would you consider it curable or not, or maybe in some cases?
Well, I think, I always tell people to think of it as a lifelong problem. Not one that they have to suffer with every day, but one that may require treatment again. And so I always think it's important as you're devising a plan for someone with trigeminal neuralgia to be cognizant of plan B and plan C and maybe plan D, because it is unfortunately likely to come back again, and we need to be ready for that eventuality. And I think that way people are better prepared in general to take care of it if and when it decides to come again.
As you've noted, there are many ways this can be managed. Even if not cured, the pain can be managed.
Correct. And, I always say the things that we do are treatments, not cures, because I want to think about that way. I want to be prepared for the next thing. We certainly do see sometimes when people have microvascular decompressions that their pain may never come back again. And I think that's a possibility, but I still want to be prepared. That's my job, is to be prepared just in case. I think with gamma knife radiosurgery, we often get long-term relief, 10 years or more for some people, but often we have to, we'll see people have the pain again, and we will repeat that sometimes. If it worked once, it usually will work again. So.
You're watching Ask Us Anything About Face Pain from Penn State Health. We welcome your questions for Dr. Jim Mcinerney. Whether you're watching this video live or even if you're watching it on playback, we can track down answers and we'll answer you in the comment field below this Facebook post. We have another question now from Rebecca. She's asking if there's a connection to fibromyalgia. She says, I was diagnosed and my whole face hurts.
Well, again, if it's both sides of the face, that's less likely to be trigeminal neuralgia. Fibromyalgia is a difficult thing to treat, and again, often it's a pain, and so as with all pains, it's often a trial and error type of process to get at what's really working. There's not really a connection between trigeminal neuralgia and fibromyalgia per se, but again, it depends on how well the diagnosis has been done. So there are people who have trigeminal neuralgia who could be diagnosed with fibromyalgia because they were never tried on those medications or something along those lines.
All right. Some great information today from Dr. Jim Mcinerney. He's a neurosurgeon here at Penn State Health, Milton S. Hershey Medical Center. If people would like more information about the clinic and Dr. Mcinerney's clinic here, we'll make sure we add that to the comment field below this Facebook post so you have that contact information. But thanks a lot for your time today.
Thank you.
And we thank you for watching Ask Us Anything About Face Pain from Penn State Health.